Respiratory diseases is what we're going to talk about today. What we're going to go over is acute upper respiratory tract infection. So we're going to move from top down and talk about obstructive diseases such as asthma, COPD, and some of the rare expiratory airway flow obstruction diseases. We'll then also talk about restrictive diseases, and then we'll very briefly talk about lung transplantation. Acute upper respiratory tract infections are something you're going to meet up with. Okay, what an acute upper respiratory tract infection basically comprise any portion of the upper respiratory tract mucosa, including nasal cavities, sinuses, okay, oral cavity, including tongue, hard and soft palate. You can also involve the pharynx, tonsils, adenoids, epiglottis, or larynx. Each one of these, if you have an upper respiratory tract infection, may lead to inflammation and may lead to obstruction of that area. If you're looking at nasal cavity, if you get infections there and you start getting edema, the person will not be able to breathe through their nose and begin to breathe through their mouth. Right? And that can be a particular problem for you clinically, because if you're trying to ventilate them through the nose, it's not going to work. And if you have their mouth completely clamped closed when you're trying to ventilate, you're not going to get any air into the individual. So you have to modify how you mask that individual, and we'll teach you that when you get to clinical. Signs and symptoms is local tissue invasion by organisms or inflammatory mediators. The inflammatory response is usually from a cellular mediated response, which increases perfusion, leads to mucosal edema, increased mucus production, and a lot of times fever. Eventually, it does cause closure of passages, and then you may then develop secondary infections, such as the sinuses. Sinuses can become infected very easily. Almost 100% of your patients that you have a nasal intubation in or have an NG tube more than 3 to 5 days in place will develop some form of sinus infection. Okay? Will it be meaningful enough to becoming a problem? It may cause fevers. If somebody has immunosuppression, it may actually get out of control. The area is drained away by lymphoid tissue, and so as a consequence, infections can spread to the lymphatic spread, and it can actually then invade into the blood vessels if the lymphatics are not in good health, which may then lead to sepsis. Normal mucosal drainage, which is usually something that we swallow all the time, we just don't even realize it, will go down to your stomach, and then some people will get nauseous and vomit from that alone, or it can actually then also get into your lungs, which of course, if it's infected, may then cause a pneumonia to take place. Now, one of the things that's pretty important for us for breathing is to use our nose throughout the day. Patients that have increased incidence of asthma are patients that have some form of nasal problem a lot of times, especially in children. If you have a deviated septum, your chance of developing asthma increases by about 20-fold or 30-fold. That's a pretty significant increase. The question is, why is that? And the answer mostly lies in that the nasal mucosa acts as a filter to prevent dust and pollen from getting down your lungs. Versus if you're breathing through your mouth, you don't have that filtration system. You don't have that increased surface area to basically absorb pollen fragments, and basically then it gets into your lungs. One of the big dangers of doing nasal cavity work is that you're going to end up having to pass through an area that has a large amount of surface area with mucosa. So it's very likelihood to bleed, which we call epistaxis, and it bleeds pretty aggressively, to say the least. And then you also have turbinates. Turbinates are these very large structures that come out laterally towards the midline. The biggest one of these is the inferior turbinate. I've seen people not put an endotracheal tube properly and do what's called inferior turbinectomy, which means they actually tear the inferior turbinate with the endotracheal tube. The endotracheal tube acts like a tube that has a hole in it, and it's a fairly large hole, so I can actually grab the turbinate, and if you keep pushing on it, you'll just tear it right off. And you're talking about bleeding, so it's pretty impressive. Now, how do you avoid that? This is not in any book, but I'll tell you how I handle it. Okay? What I use, if I'm going to put a nasal intubation on anybody, is the first thing I put through the endotracheal tube It's not a stylet. There's just no point in that. You're not going to put anything rigid through it. Instead, you put an NG tube through it. Okay? So what the NG tube does is it fills up the hole of the endotracheal tube. So it no longer acts like a trocar to grab onto the tissue. What I also do is I take the NG tube, which is specifically designed to go through the nose to cause the least amount of trauma, as a guide. So once I have the person asleep, I'm ventilating them, and then I want to nasally intubate them, I pass the NG tube first, which is a smaller diameter. Once I get it back into the nasopharynx and into the oropharynx, then I will put the endotracheal tube over the NG tube. A lot of times, if you're doing this technique, if you leave the NG tube to do its normal curvature, which is you're letting the C moving upwards, if you just feed it in, you actually a lot of times will already be in the larynx. So you can actually pass the tube right directly into the larynx without having to do anything else special. It's kind of a nifty little trick. I basically got frustrated over the years seeing a lot of complications from nasal intubations. So I said to myself, there's got to be a better way. And one of the things that I do, which is unique, not unique, but it's different. I went back and read what the old guys used to do. And they would actually do dilation with their fingers. And I do that to this day. I put on surgical gloves, and I will dilate somebody's nose with my fingers. Okay, when people first look at that, they go, whoa, that's really gruesome. But the nice thing about using your fingers is you have feedback. You know if the person has a deviated septum. You know if the person has a large polyp in the way. And of course, when you feel that with your finger, you're not going to keep pushing. Okay? And my fingers, I take the endotracheal tube and put them beside them, and tells me the size of my size tubes that I can put in. 6, 7, 7.5. Okay? So I can basically dilate the person's fingers with your fingers, and you're going straight in, which tells you the exact direction you need to go. You switch your fingers, and you keep doing that. And now you've got the patient fully dilated. Some people say, well, that's gruesome. Well, that's fine. Okay? If you don't like doing it that way, then you can use the nasal trumpets. I personally don't like nasal trumpets in that sense because you don't have any feedback, and I've seen people tear up the mucosa to be a problem. So there's different things you can do. If you get into trouble, you can stop hemorrhaging by two ways. One is by putting a Foley catheter in somebody's nose and inflating it. Okay, the Foley catheter balloon will compress the area and stop the bleeding, so if you're desperate. There's another really nifty trick that I use in the field when I have kids get injured or something. I go up and grab the top of their forehead like this and pull up. Okay? It seems kind of weird. It's like, why are you doing this here to stop bleeding? The arteries that run down towards the nose are running right here. So if you put direct compression on it, the bleeding immediately stops. It's a nifty little trick. Okay? Again, that's not really widely distributed in too many books. But you can do that as well clinically. When somebody's lying down, you can just put compression on it, and it stops the bleeding. And you hold it for about 5 minutes. And then usually the bleeding is coagulated and stopped. You can also induce sinus infections, of course, by leaving endotracheal tubes or NG tubes in place for too long a period of time. And one of the big scary things is if you have a cribriform fracture, which is up here, and you head your NG tube or your endotracheal tube in that direction, you may actually pass through the cribriform plate and actually enter into the brain. And that has a lot of negative potentials. If you look at your head and neck lymphatics, your tissues, which are called the adenoids, the tonsils, and the tongue, all have in them some form of lymphatics. Specifically, tonsillar bed and the adenoids are big lymphatics. They drain posteriorly along the lymphatic chain in the neck, and they do a pretty effective job of draining. So one of the things that you can do if somebody tells you, well, I've got an infection in my mouth or something, one of the things you want to go to is for the neck. And it tells you pretty much which side it's on. Okay, it's going to stay ipsilateral, which is on the same side as the injury with infection. These are kind of problems that you are going to encounter, and these are real airway disasters. Okay, if you look at tonsillitis, these are the tonsillar beds. This is not normal. Okay, this individual's tonsils are touching each other, and the uvula is trapped in between them. This person would be a nightmare to intubate. Okay, you're not going to be able to move the tissue out of the way very easily. And you're going to have a very limited view when you're intubating this individual. You can also develop adenitis. That's more posteriorly and upper, and it can be difficult to nasally intubate those individuals. You can also get what's called a peritonsillar abscess, okay, which is right around here. The peritonsillar abscess will actually enlarge so significantly. This is what a peritonsillar abscess looks like. You can see it's pretty nasty looking inside this person's mouth. When you have the person open their mouth, you pretty much roll over from the smell. It's pretty severe. You can smell the infection. And inside this big pustular pocket, you can see how the uvula has become hugely enlarged. It's all pus underneath there. Okay? So what you need to do is, and this is kind of difficult when you're first starting. I've actually had a situation where we went into the operating room and they told us, oh, we're gonna want you to intubate this individual. And I had a case about 2 weeks beforehand where the guy was completely obstructing, and I was calling the ENT surgeon in to come in to drain this. Instead, he told me just put a 50 cc syringe on it, put a spinal needle on it, and just put it into the abscess and drain it. And it works. You can actually drain 50 to 60 cc's of pus out of there, and immediately the airway becomes nice and open again. And the safety profile on that is that usually these things are tight, so they're ready to burst, okay? And if you get in there with the blade and hit it, it'll burst open just when you're trying to intubate, and then you have purulent material going all the way down the lung, which is not a good outcome. People can get really, really sick. So a lot of times you need to consider putting a needle into it before you start doing the case. So drainage is really the way to go. If you have a very young surgeon, you won't really know that trick, but the old-timers really do know how to do that, and they put in the needle with not too much problem. A very deadly one can also be much more severe to deal with is epiglottitis. Epiglottitis is called thumb sign. You can see how large this epiglottis has become. It looks like the thumb, looking at it laterally. Okay, so that's why it's called the thumb sign. It's a form of infection from many different kinds of bacteria. It is life-threatening, and it can be very difficult to manage these people. A lot of times we try to let them spontaneously breathe. I'm more of a fan of getting there with a fiber optic scope while they're awake and intubating them awake. I'm not a real fan of trying to do these people asleep. So I numb up the airway adequately, and then I go in there with a fiber optic scope, spray the cords with lots of local, and then I let them spontaneously breathe. I'm not a real fan of putting these people to sleep, and then they collapse, and then you're screwed. Then you got to put in a trach or cricothyroidotomy in these individuals. Not something I really want to do again. I have to. You can also get what's called papillomaviruses. We're going down further. Papillomaviruses are infectious to you as well. You can see these are actual viruses that actually cause condylomas and will actually begin to cause polyps. Well, they're really condylomas, but they look like polyps. And they will line up the vocal cords and basically begin to obstruct the airway. And it will make it difficult for that person to phonate properly. The way we treat it is we put a small endotracheal tube in these individuals, and then they're lasered off or burnt off. Okay? And the danger of the burning or the laser is that it causes smoke plumes to develop. The smoke plumes have active virus in them. Okay? So those smokes should be now suctioned away with special devices. But if not, or even if it is, I personally wear my mask and make sure that it's extra tight so I'm not inhaling the stuff. And I don't put my face anywhere near where the surgeon's working. So I step back usually 4 or 5 feet away. So hopefully this stuff will not get into your lungs or airways. It can cause a ball valve occlusion, and there's of course risk of bleeding, and there's increased risk of cancer. You can also develop laryngitis or croup. Okay, that's my favorite seal here, and you can't miss croup when you hear it. It's pretty pathognomonic when you hear it. If you've never heard what croup sounds like, you will one day. It's usually seen more in kids because they have smaller diameter airways. It's from an infection, usually from parainfluenza or diphtheria. It's much more severe. The signs and symptoms are usually fever. The kids get a seal, barking cough, and the nocturnal cough is much, much worse than during the daytime. And of course keeps the parents up. Usually that's why they come in at 11 o'clock at night with admissions, because the kid's not really sleeping. And it's very much life-threatening. You need to bring these kids in and we begin to treat them with antibiotics or antivirals to get them under control. You also have, some people use Decadron and or racemic epi. Racemic epi will work faster than steroids, but has a very short half-life. So anytime you use racemic epi on anybody, you got to admit them in the hospital. It means you can expect rebound effects when they go home. So you can't let them go home. The best way of treating this also is to give cool mist, although it's never been proven. It has very little downside. So almost everybody does that. The other thing that we're sometimes asked to do is we're asked to start somebody on Heliox, at least in the past we used to. And it helps to alleviate some of the turbulent flow created by the supraglottic edema. And thus improves stridor and decreases work of breathing. The other thing that's now being used more so is BiPAP, which is you put positive pressure in the airway, which decreases the increased work of breathing. And it seems to work, but I've seen it work and it seems to work pretty well. But in children, sometimes they won't want to hold a mask on their face. The next step, of course, is intubation. And you need to anticipate that they're going to be difficult and make sure that you have a smaller size endotracheal tube than normal. The last one of the upper airway is supraglottic infections. Subglottic infections basically occur when you have edema forming, possible in the trachea or right below the larynx. Okay? In these individuals, intubation may be almost impossible. Even if you have the vocal cords wide open at the top, you can't pass the tube below it. And crikes are basically ineffective. So really the best treatment for this is to do a tracheostomy awake. So this is a very, very dangerous situation. I would recommend that in this situation to put the person on BiPAP on a mask while you're doing the anesthetic under just awake with sedation, but mostly awake. If you put these people to sleep, you'll lose the airway, almost invariably. Obstructive disease is asthma. We've talked about this a lot, but I'm going to go this pretty quick. It's a hyperreactivity of the bronchioles. The bronchioles can constrict and cause an obstructive process. It's more frequently seen in children because of smaller bronchial size, and some kids will actually outgrow it around the age of 12. There's a 2-to-1 male to female incidence, and there's about 3 to 6% of the U.S. population. There's, of course, activators. Most of them are environmental activators, such as inhaled or ingested antigens, molds, dust mites are big culprits, feathers, and animal hair. Dust mites can be reduced significantly by several things you can do. Making sure that you have certain kinds of pillows, make sure that you have pillow covers on your pillows. If you don't have pillow covers on your pillows that are basically impermeable, the dust mites will get into the pillow itself and begin to feed off your skin. The other things that will happen, and that's really become a much bigger issue. Dust mites are really becoming a very high initiator of asthma. We also get reflux, can be also an asthma activator, so some of these kids will be done with special tests to see if they're having chronic reflux. Chronic infections, strenuous exercise can also activate it. Hypothermia or cold temperatures a lot of times will induce asthma. Overreaction by the immune system is an issue. And what you see, asthmatics are higher risk, the ones that are not breastfed at young age. Parasympathetics versus sympathetic activity, normal response to bronchodilation with sympathetic activation. In asthmatics, you don't see that as a consequence. You have more of a chronic bronchoconstriction taking place in these individuals. It's a disease pretty much of the small airways. It's an inflammatory response. And it begins to actually finally alter the bronchioles in a way that, if you don't treat it appropriately, will basically become irreversible. You actually have significantly increased bronchial responsiveness. So even somebody who says, well, I'm not really, how many times have you had asthma in the last year? Maybe once, and it's not severe. And that person has a lower risk. If the person's telling you that they're being admitted every month, that person's a higher risk to develop problems. That doesn't mean that that if you put an endotracheal tube, everything will be fine in a low-risk individual. It just means that the incidence of having problems is lower. But you can still get into trouble with it pretty quick. The actual initiating event of putting an endotracheal tube can be very stimulating, causing very severe bronchospasm in these individuals. One of the primary treatments that I use if I think this person is going to be hyperreactive is I use LTAs a lot. The books don't necessarily say that to you again. Some people just say you use bronchodilators. I've really been very disappointed with bronchodilators most of the time. They don't seem to work as fast as I want them to be. So instead I use an LTA because I think most of this reactivity is due to the laryngeal response and also the tracheal response to a foreign body in it. So the lung is basically trying to protect itself from this invasion. So by putting in a local anesthetic, you shut off the afferent stimuli and the bronchoconstriction goes away. We had that event happen the other day. We had a person emerging from anesthesia. They had been doing fine the whole case. So significant asthma in the past, but nothing recent. Did really great during the case, but on emergence, as soon as she started emerging, she went into bronchoconstriction. I mean, she really tightened up. You could feel in the bag. So we tried the bronchodilators for a few seconds. It didn't do anything. We didn't want to deepen the anesthetic. We wanted to immerse the person, so we had no more gas on board. I think that's why she started developing bronchospasm. So we shot the LTA down, shut down the system, bronchoconstriction stopped. Within 30 seconds, then she was breathing again on her own. And we got her extubated in about 3 more minutes. So it really makes a difference in that situation. You can't deepen the anesthetic, so you're starting to stuck. That's where you can get into trouble and get negative pressure pulmonary edema or other complications. It is an occlusive disease and increases airway resistance, and it is reversible most of the time. Signs and symptoms early is dyspnea, mild expiratory wheezing, cough. When you're looking at the mid, you have increased work of breathing, increased respiratory rate, and you get moderate to severe audible expiratory wheezing, and you're sitting up to breathe. That's a pretty pathognomonic sign of somebody having severe asthma attack. And then late, you get this very familiar face. I've seen people with this kind of face. It's from the adrenaline that's getting hypersecreted into the bloodstream, and fear, partly, of course. And they'll start developing increased work of breathing to the point that they're becoming exhausted. And you may actually hear no breath sounds. That's really, really bad. Okay, when you hear no wheezing at all, that doesn't mean the asthma is getting better. It's actually becoming terminal. And that person cannot move air anymore. So sometimes we're actually asked when people get into that point to put people to sleep under anesthesia, to break it with volatile anesthetics. Sometimes that's very effective. Measurements of asthma can be used with spirometer. You have decreased tidal volumes, reduced vital capacity. Your total lung capacity is increased, and you have an increase in FRC because I guess it's an obstructive process. Your forced expiratory test shows you that you have reduced FEV1. The more severe the FEV1 reduction, the greater the worsening the disease. Your reduced forced expiratory flow of 25-25 is also reduced. Your forced vital capacity is reduced, but not as much, and so your overall FEV1 to FVC ratio is significantly decreased. Your measurement of asthma can also be using diffusion tests are normal. Your flow volume loops will show that the person has obstructive process. And then you have your end-tidal CO2 will start showing these kind of signs. This is how you pick up in clinical that you have somebody with asthma. Start seeing that the end-tidal CO2 becomes very sharp and increased. The worsening the disease, the worse it is. Now the other thing that happens is that your end-tidal CO2 is no longer predictive of really what the CO2 is doing in the body. Okay? Because you no longer have a plateau phase. With no plateau phase, you really don't know what the end-tidal CO2 is in reflection to the PA CO2. If you look at pressure over time, you get a high peak inspiratory pressure, but the plateau is unchanged because this is an obstructive, restrictive, you're getting obstructive process, so you're getting high peak inspiratory pressure, but your compliance on your lung is essentially normal in the early part of the disease. As the person worsens, they may actually start developing pressure, some degree of pulmonary edema, which then will alter the actual plateau phase on the pressure over time curve. ABG findings for mild asthma, you have normal PCO2s and PaO2s a lot of times. You do notice that the person has tachypnea and hyperventilation, not due usually to hypoxemia in this early stage, but usually hypocarbic and alkalemic slightly. If the person worsens and the person develops fatigue, you'll get eventual rise in CO2, and the FEV1 is usually less than 25% at that point, and you start seeing a significant decrease in your PaO2. Chest X-ray shows hyperinflation, and then EKG starts showing right ventricular strain patterns, right heart failure, and ventricular irritability. You see a lot more PVCs. Classifications of asthma can be based on what initiates it. You can go allergen, exercise, nocturnal, aspirin-induced, occupational asthma, or infectious asthma. Aspirin-induced is really a nightmare. You've got to be very, very careful. Those individuals that usually have nasal polyps associated with them too. Let's go into the different ones. You have the allergy-induced asthma. It's the most common form of asthma. It of course, has some degree of genetic predisposition. Some people have what's called atopy, which is that's the single biggest risk factor. When you look at their the way they react to things, is that when you scratch their surface, you'll see that their skin will form red lines. That's a way of describing the person has atopy. It's an antibody activation by allergens. And usually asthma is an immunoglobulin IgE-mediated event. So you're looking at type 1 immune response. So it can be pretty quick and rapid. IgE binds to allergen mast cells, and the mast cell causes activation, which leads to granulation, leading to histamine, slow-reacting substances, anaphylaxis, and prostaglandins to be released, which then leads to intense immune reaction, leading to bronchoconstriction and all the bad events that you see. This is what atopy looks like. Okay, you can see it's an allergic reaction. It's an allergic hypersensitivity, which is a type 1. It affects the body not in direct contact with allergen. Okay. Because the reason it's not the part that's direct contact is because it's causing histamine release. So other parts of the body will actually develop these kind of problems. You have elevated levels of IgE and allergy-specific IgE as well. And they have what's called a positive skin prick test. We do these patients a lot for children. We do them under anesthesia while their person's asleep. Usually when they come in for tonsils or some other thing, they'll get allergy tested. And the reason that is because you imagine poking this many holes in a kid, they're not going to be real happy about it. So doing that under anesthesia is actually a little bit nicer. You can also have exercise-induced, and you can see here Jackie Joyner Kersey. She's pretty famous, very, very great sprinter, and she has very severe asthma, but she treats it appropriately. So it's amazing, even athletes have it. You can also have cold weather exacerbates it, and decrease in airway temperature from increased flow to the airways seems to activate this. You also have nocturnal asthma. It's sleep-related. It's the circadian variations in catecholamines. We think that's because cortisol levels drop so drastically at night. It could also be from GE reflux, or the other thing you got to think of, it could be due to dust mites, these little friends sleeping with you every night. So if you're having asthma every night, it's time to change your bedding. Okay, take out your bed, throw it away, put plastic covers over your beds. Some people don't want to spend the extra money. It's well worth it. Dust mites cannot grow on plastic, or at least they don't live very long. They love, though, cloth, though, in the bedding, and they love to get underneath inside of it. And then they just come to the surface in the evening and feed off the skin. So it's lovely how the microenvironment around you survives. You also have aspirin-induced asthma, and this is pretty significant in the sense that even small doses of aspirin can cause an idiosyncratic reaction, which is pretty severe. They usually present with rhinorrhea, conjunctival infections, nasal polyps are pretty common. And we think that the reason this is because aspirin actually blocks the cyclooxygenase, thus inducing bronchoconstriction. These individuals, when you take care of them, they have a higher propensity of bleeding, okay, in the mucosa. They also have a higher propensity of developing very severe asthmatic attacks. So be very careful with aspirin-induced asthmas. Then you have occupational asthma. Being a guy that likes to work around the house and likes playing around with stuff, you got to be careful with working with woods as well as concrete. A lot of people don't think about this, but when they're building airplanes, like balsa airplanes and stuff like that, balsa is very, very bad. It's such a light wood that it can get into your lungs really easily. So if you're working on that stuff and sanding it a lot, make sure that you wear a mask when you're working with it. Over time, you will develop occupational asthma from it. Of course, you can see construction workers. How many times do you see them wearing a mask? Almost never. But do they get sick? Oh, yeah, all the time. And when you put them to sleep, it's a nightmare. The way you pick up on it that they have a lot of exposure is look at their eyes. Their eyes, their conjunctivals will be bloodshot. Usually it's from chronic exposure to things like concrete dust. And their lungs are going to be the same way when you put them to sleep. They're going to be hyperreactive, and they're really a nightmare to put to sleep. Infectious asthma, of course, is from infectious agents. It can be anything, virus, bacteria, mycoplasma. Treatment is, of course, eliminate infection and increase mucociliary mechanisms. That's easily said. Done. Sometimes treatment options include prevention and control. Okay. Anti-inflammatory agents sometimes are used for chronic asthmatics. Steroids have become a really big first-line therapy. And the old way of doing it was to give PO, which is really not the better way to do it. Instead, we're now doing it via meter-dose inhalers. Things like beclomethasone or triamcinolone can be done that way. It gives you minimal side effects and no adrenal suppression, so you don't have to worry about having a person develop adrenal crisis when they're on those things. The only downside to it is that the steroids will immunosuppress the oropharynx and cause increased risk of developing oropharyngeal candidiasis, which is a real nasty process, which I showed you pictures of before. You can get glossitis and dysphonia as well. Some people are actually using also cromolyn as an antibody binding agent. It's only used in chronic therapy, never use it in acute symptoms. If you treat bronchospasm, you can give a bronchodilator. Some of them are basically increase your intracellular cyclic AMP, things like theophylline and aminophylline. I'm not a real fan of those, especially not in the operating room, because there's much increased risk of developing malignant arrhythmia. So because of that, every time somebody sounds on theophylline, I shut it off when they get to the operating room. I do not use it in the operating room. Instead, we use more like beta-2 agonists, such as albuterol. It's pretty much our first-line therapy. The anticholinergics sometimes are used as well, which is ipratropium bromide, which is a substance that looks very similar to atropine. The nice thing about ipratropium bromide is it's not as causing tachycardia as atropine. And it also is a quaternary ammonium, so it limits the systemic absorption into the brain. So you don't get the same level of anxiety that you do as you do with atropine. Volatile anesthetics will also break asthma, and you can deepen that person, or using Heliox may also help. I personally use LTA. So, asthma induction, basically you want to depress airway reflexes, regional if possible. And if somebody asks you what's the best anesthetic agent of choice for induction, the answer is going to be ketamine. It's one of those few questions where you can actually use ketamine. The reason ketamine is such an effective choice is it increases sympathetic response. The downside to it is it increases salivation. So a lot of times you have to give it with anti-sialogs, such as glycopyrrolate with it. It does not protect you from aspiration, of course, remember that. The other thing you can do is when you're using volatile anesthetics, the books, I don't agree with pharmaceutical companies saying that Desfrain is fine for somebody that has severe asthma. I'm not a real fan. I've seen people get in trouble with it, so I'm not a fan of Desfrain when it comes to bronchospasm. Instead, I use something else which I can deepen and I can reliably not get into trouble with. So Desfrain is pretty much out for me when I'm using an asthmatic or somebody who has severe bronchoconstriction. IV lidocaine or lidocaine also will inhibit the response, and you want to avoid any of the neuromuscular agents that cause histamine release, which may cause you a problem. If you're developing asthma, all of a sudden consider deepening them, or you consider using LTA, or you can do deep extubation as well. I'm not a real fan of deep extubation. To do deep extubation, you have to have a person who has no risk for aspiration, which a lot of times you don't have that choice. The other reason I don't like it is that most people don't understand what deep extubation is. Deep extubation means that you go to a high level of volatile anesthetic, okay, and allow them to spontaneously breathe at that point. So now they're still under deep general anesthesia. You need to do a twitch monitor and do a tetanus and see if the person reacts. If the person does not react at all, you have them deep. Okay? What I do at that point is, if I don't have a patient with asthma from aspirin, I will put a nasal trumpet in, or sometimes use an oral airway, then extubate the individual rapidly. Okay? And then let them spontaneously breathe for a little bit with the gas on, and then after that, then I shut the gas off and let them wake up from it over time. Now, the reason I don't use nasal trumpets in patients that have aspirin-induced asthma is because they have nasal polyps, and also nasal trumpets will activate a reflex response of the larynx and the bronchioles to cause severe bronchospasm in some of these individuals. So be very, very careful. Watch your inspiratory time, prolong the inspiratory time, and more time to getting gas into the patient. You increase the peak inspiratory pressure, should be expected. Okay? Avoid PEEP in these individuals because this is an obstructive process. Avoid dry gas, so always consider humidification, and maintain normothermia. Situations that mimic asthma can fool you, and this is always what you need to. What I always do is I work from the patient back to the anesthesia machine. So you want to look if the person has any kind of kinking in the endotracheal tube or mucus. Patients biting the tube, which also can happen. If you have inadequate anesthetic depth, if your main stem intubated, if you had some kind of pulmonary aspiration, mucus plug may also form at higher incidence in asthmatics, you can imagine. Early pulmonary edema may also form, and pulmonary embolism may also produce bronchospasm. So you got to think of all these possibilities, not just say, well, the guy's wheezing and that's just asthma. Not necessarily. Sometimes it could be pulmonary edema. It could be congestive heart failure. You gave too much fluids. COPD is the next disease process, which is chronic obstructive disease process. It's two diseases in one, and they're both diagnosed at death usually. It's either emphysema or bronchitis. Both are clinical diagnostic. Emphysema should be really done by a biopsy, but nobody does that. Instead, we just call it COPD. And the bronchitic component usually that you have chronic disease of the actual bronchioles for more than 3 months. Bronchitis is usually damage to the bronchioles, and you usually get increased mucus production. You get damage to the mucociliary mechanisms, and a lot of times you get secondary infections. COPD is still the 5th leading cause of death in the U.S., and it affects about 10 million people in the United States alone. So it's a pretty big problem. In Europe, it's even a bigger problem. It really is. They smoke like fiends. At least in this country, you've got the reduction in the number of people smoking. Males in the United States only smoke at around a 15 to 25% rate. Women are actually exceeding the men. They're smoking around 30%. European men smoke at 90% rate. If you don't believe me, go to the coffee shop. You can see some of our European friends here. So, the haze, yep. Hallmarks of COPD is that there's permanent or minimally reversible obstruction of the airway. Okay? You have exercise limitation, dyspnea, chronic productive cough, and increased work and breathing. Not to say that Americans are healthier than anywhere else in the world. We may not smoke, but sure as heck we got a lot more obesity. So, everybody's got their own problems. But Europeans definitely do smoke a lot more. Now, this disease I've seen it significantly diminish over my lifetime. Okay? When I first became a resident, we used to see a lot of people with very severe forms of emphysema. So they were the pink puffers. They'd be these emaciated individuals with significant weight loss. They would have increased work of breathing. It's literally because their chest cavity is huge and they can't move air. They're not usually cyanotic, but they definitely look emaciated. Think that when you look at them, that they have cancer instead of have just a COPD. The ones that are the other type with the blue bloaters, these are the bronchitic, so B for B, in other words, type B with blue with bronchitics. So it sort of tells you a little bit about the disease. They're going to turn blue, so they can be cyanotic. They're going to have increased work of breathing. A lot of times these people are basically sedentary because they just can't get enough oxygen in when they start walking around. So unfortunately, they gain a lot more weight. You get pulmonary hypertension over time, cor pulmonale, and eventual right-sided heart failure. Some people, of course, have some genetic predisposition. I had one lady that was 89 years old. She asked me if I should stop smoking, and I looked at her and was like, why? Why would you stop smoking at 89 at this point? You've enjoyed smoking for 69 years. What are you going to stop for? And if you did a test on her alpha-1 antitrypsin would be through the roof. She's a lady that was smoking for 60 years, 2 packs a day, with no effects at all. And that's just because her genetics. She's just lucky. There's other people that have what's called alpha-1 antitrypsin deficiency, which accounts for about 20% of the population. And when you have this problem, it's a serine protein inhibitor. It basically causes you to develop severe damage very rapidly from activated neutrophil granulocytes. So normally this alpha-1 antitrypsin inhibits that activity. So a deficiency leads to uncontrolled elastase activity. So you get an increase in elastine destruction and leads to very early, young individuals with type A COPD. I'm talking about in their 40s. Okay, it's pretty impressive. I've even seen a guy that had it in their 25. He started smoking at 15, and by 25, he already had very severe emphysema. Cor pulmonale is usually seen in type Bs. These are the patients that develop pulmonary hypertension. They eventually lead to left ventricular failure, leads to VQ mismatch, and they get HPV. Hypoxia develops very rapidly in these individuals, and they get right ventricular hypertrophy, right ventricular dilation, which is a bad sign, and eventually failure. The failure leads to hepatosplenomegaly, ascites, and peripheral edema. So comparatively, COPD can be a significant disease differences, and some people have a mixed capacity in here. Well, if you look at both of them, you see that the FEV1 is reduced in both of them. Okay? Dyspnea is much more severe in the emphysematous patient, but bronchial obstruction is worse in the chronic bronchitic one. You have significantly elevated CO2 levels with the bronchitic, the type B, and you have more levels of low PaO2 in comparison to the emphysematous one. COPD should be diagnosed with PFTs, chest X-ray, arterial blood gases. Your PFT data shows a normal to a decreased vital capacity, so that's really not where the problem is at. Your total lung capacity is actually increased a lot of times. Your residual volume is then the biggest culprit of the problem, is the residual volume is increased, okay, from normal. Your FRC is also increased, and your expiratory reserve volume may actually be decreased in these individuals. Okay, so the payment is actually in the residual volume. Your COPD patients with looking at the FEV1 to FVC curve, your FEV1 to FVC is decreased, obviously, versus restrictive disease if it stays unchanged. If you look at your decreased FEV1, you're looking at less than 70% is around mild disease, 50 to 69% is considered moderate, 35 to 49% is severe, and then less than 35% FEV1 is very severe. Those patients don't tolerate anesthesia very well. You have to be very careful with them. They also have associated with them decreased forced vital capacity, but not to the degree of the decrease in FEV1. Chest X-rays, you can see this person has hyperinflation syndrome. The chest X-ray shows the lung is actually hyperlucent, so the chest rate looks blacker. You get hyperinflation with a very flat diaphragms, and you can see bullae in the top of the lung from the damage. The heart looks very vertical, and simply because the chest is getting so large. If you look at your blood gases, okay, COPD, type A patients are not the ones that are cyanotic, so usually they have PaO2 greater than 60, versus the type Bs are less than 60. Remember, 60 is compared with saturation of what? 60, 90. Okay, so these people are below 90% saturated a lot of times. Type A's have normal CO2s versus these. Type B's are elevated because it's more of an obstructive disease process. pH is normal in type A's, saturation usually normal. Hematocrit is normal. Diffusion capacity is decreased. In type B's, you get elevations in CO2. Because of that, the person begins to compensate for it by increasing bicarb by the kidney, and it significantly can increase to almost normalize the pH. The pH a lot of times is usually decreased, but it's only mildly, especially if the person compensates. Saturation, of course, is decreased. You're going below 90%. Increased hematocrit, and diffusion capacity is normal in comparison to the type A, which is abnormal. Treatment is get the people to stop smoking. The sooner the better. Supplemental oxygen sometimes will be used to give that person less of a right ventricular strain, because at least you cut back on the HPV. Drug therapies include bronchodilators, anticholinergic, inhaled steroids, antibiotics. Diuretics and lung reduction surgery may also be done, but it's only lung reduction really only is going to work for the type A's, because type A's are more of a structural damage. And they're if you look in the actual compliance portion of the curve, they're all the way on the top of it. Smoking cessation. If you're asked to tell somebody, well, when should you stop smoking? And my answer is 24 hours before surgery, because usually you're seeing the patient within 2 weeks before surgery or less. If you tell them to stop then, you're going to get into more trouble, believe it or not. So tell them on the day of, 24 hours before, do not stop smoking, okay? So the reason you stop smoking 24 hours is that it decreases the carbon monoxide levels in the blood. So carboxyhemoglobin goes down from 6.5% to down to 1%, which is good. Yeah, the saturation improves significantly. Okay, it decreases nicotine levels as well, which decreases sympathetic response and decreases vasospasm. The P50 also shifts back to a more normal place from 22.9 to 26, which is a better ability for oxygen transfer. And it's really not advised for more than 24-hour cessation if you have somebody who's chronically smoking. Because what you're going to get into is you're going to get increased bronchospasm, increased mucus production, and it's really nightmarish. Okay? And I've seen people tell people, oh, well, you know, stop smoking 2 weeks beforehand. By the time they walk in, they're a mess. First of all, they're jumping up and down. They're completely in withdrawal. And the next thing they are is that they're hypersecretory. So when you intubate them, the mucus is so thick that the endotracheal tube completely clogs off. So try not to do that to yourself. Advise, if really the best situation to be is you have to be, if you really want to be perfect, is say stop smoking 8 weeks prior to surgery. In the United States, nobody waits 8 weeks for anything. Okay? So anything can happen. Okay? So what you can do is you can tell the person to stop smoking as soon as they can after the surgery. Cell metaplasia will be reversed, immune response is restored, hepatic enzyme levels return to normal, mucus production is actually normalized, you get decreased bronchospasm and improved wound healing. And a lot of the back surgeons are not allowing their patients to smoke because they know that the healing rate and the infection rate goes way up if a person's continuing to smoke. So a lot of the surgeons are now telling their patients to stop smoking 8 weeks prior to elective back surgery. General anesthesia versus regional. Regional may offer some advantages, but not always. One of the things you've got to avoid is T6 or higher blocks. So if you're doing abdominal surgery, I recommend doing a regional. Be very careful. You might get really burned with it. General anesthesia may have a higher complication rate, but really may be due to the actual procedure, because why are you intubating that individual is you're doing a bigger procedure. If you're doing a peripheral procedure like a total knee or something, you usually do it under spinal. Versus if you're doing an abdominal procedure, you're going to have to do it under general. So it may not be the actual anesthetic, but actually the procedure that's putting that person at a higher risk. It's hard to sort of separate those two out. When you actually look if the person is going to do fine with hip or for a total knee under general versus a spinal, there's been no found difference between the outcomes in the end. So when people tell you that, well, it's safer, it depends on who's doing it. Okay. If you look at volatile anesthetics, they're bronchodilators and they're easily reversible. The downside to them, of course, is that they all reduce. And you put somebody under general anesthesia, you can reduce their FRC by about 20% from the start, and they may actually put them into the point of failure. Nitrous may actually exacerbate pulmonary hypertension as long as you keep it under 50%. It's usually not a problem. Where you may get in trouble is that you may actually rupture a bullae. Opiates may actually be very effective, but also downside to them is to suppress respiratory drive. And somebody who's chronically hypercarbic, it may become a real issue. Humidification is pretty important. Ventilator management is that be careful with positive pressure ventilation because these people are already hyperinflated, so they're going to be more sensitive. I don't give them large tidal volumes. They don't tolerate peat ball as well either. So I give them plenty of expiratory time. And what I try to do is I decrease my inspiratory flow rate and increase my I time at times to make sure that the person inflates properly, but then give them enough expiratory time as well. Monitor for saturation and end-tidal CO2 is maybe very inaccurate, especially if you have a slope on it. So you have to be basically sometimes check your blood gas to see what the correlation is. Post-op complications are common, unfortunately. You get a reduction in FRC to the point of exceed at closing capacity. So atelectasis in these individuals is much more common than a normal individual. You get a greater degree of VQ mismatch, decreased vital capacity, decreased cough reflex, increased risk of pneumonia, and increased risk of arterial hypoxemia. There's increased risk for complications of neurosurgical, intra-abdominal, or intrathoracic procedures. Again, why is that? Because all these procedures may be affecting the respiratory drive centers or the muscles that affect respiration. You may also get impairment of cough reflex, and long surgical procedures also increase risk. Prevention is considered continued mechanical ventilation in some of these patients. Post-operatively, these patients you should be told ahead of time that there may be a chance that they may not be extubated at the end of the case. The other thing I make sure is that all these patients are adequately reversed. The other thing to consider is to give these people good neuroaxial post-operative analgesia, such as either Duromorph for spinals or an epidural to control pain. Some people use TENS. I don't think that's really that effective. Regional blocks are pretty effective. The only thing you got to be careful with is interscaling blocks. They actually knock out the phrenic nerve, and they may be also, if somebody's already marginal, you may get into trouble with it, so be kind of careful with that. Make sure that you do re-expansion maneuvers to make sure at the end of the procedure so the lung is properly reinflated before you extubate them. I do what's called a manual inspiratory capacity maneuver, and what you do is you squeeze the bag after you close off the pop-off to 40 centimeters of water, and you hold it for 7 to 8 seconds, and that re-expands the lung properly. And then I proceed to go on to get them extubated after that within a few minutes. You can also use intensive spirometry for the person to really help themselves preventing some additional atelectasis. CPAP therapy may also be a consideration, but you've got to be very careful. If you have the person severely hyperinflated, it may not be the best idea. Usually what happens in these individuals, you get a reduction in FRC during the case, and they hit closing capacity. So CPAP in that situation may help open up their lungs. And then you can consider doing chest physiotherapy. Less common airway airflow obstructions are things like bronchiectasis, cystic fibrosis, primary biliary dyskinesia, and bronchiolitis obliterans. Bronchiectasis is basically localized and irreversible dilation of the bronchus. It's an inflammatory process, usually from chronic infections, such as bronchopneumonia, and also very commonly due to Pseudomonas aeruginosa. It leads to increased mucus production, productive cough, and also you get an increase in granulation tissue, which increases the incidence of hemoptysis. Treatment of bronchiectasis with antibiotics, postural drainage is a big thing. You can see how the mucus becomes completely clogged in these individuals. When you put an endotracheal tube in these individuals, when you pull out the endotracheal tube, it comes out like a big mucus plug. It's pretty bad. And sometimes we'll actually completely occlude your endotracheal tube. I saw that happen twice in my career. And all of a sudden, you just can't ventilate the individual. You just got to stop. You can't freak out. You just got to pull the tube out, which is almost like the worst thing you can imagine doing in that situation, and then re-intubate them. Okay? And it will work. The other thing to consider doing is if you have an Eschmann stylet, is you can pass it through the endotracheal tube to break the mucus plug and get yourself out of trouble until you can exchange it. Okay? Usually at that point, these people can get into trouble pretty severely. Now, one of the things that I think happens pretty often in the ICU is that you have people with this kind of disease or have somebody who has severe bronchitic disease or type B, and the mucus plug will begin to start to line the endotracheal tube. And you think you have an 8-size tube in the individual, and about a week later, you're actually down to really a 4-size tube. And you can't get this person extubated. And you're going like, why can't I get this person extubated? And you use pressure support in those individuals, and then all of a sudden you pull the tube out and you look at the tube and you have this small little diameter going through, but you're able to do it with PSV. Something you don't see too much in the operating room. You got to make sure that you consider doing double lumen tubes in some of these individuals and avoid nasal intubations. There's increased risk of epistaxis in these individuals. Right? So, the next one is cystic fibrosis. It's unfortunately it's an autosomal recessive disease that can be lethal. It is lethal. It's a chromosome 7 mutation. What happens to these individuals? They lack the chloride channels, and they develop high sweat chloride concentrations. The defect basically affects any exocrine gland in the body. That means all of them, okay? Mouth, airways, pancreas. So it's not a good thing. They get abnormal sweat and viscous mucus as a consequence. So their sole layer, which is the thin layer, becomes extremely thick, and then the mucus inside their lungs is not able to clear. So they get inspissated secretions. And the mothers usually will come in and tell you that the kid tastes salty. Maybe when they kiss the kid, the kid tastes salty. Okay? So they have a higher sodium content in their sweat. They get widespread mucus plug formation not only in the lungs, but also in the pancreas and all the other exocrine glands. So this is what, look at all the diseases, all the different organs that be affected by cystic fibrosis. It's pretty significant. Treatment is basically physiotherapy to clear the airways, humidification therapy, high-frequency chest physiotherapy, which means that they basically thump on your chest. Bronchodilator treatment, reduction of viscoelasticity of sputum, and then they can also give antibiotic therapy. A lot of these kids will get infected. Management is basically similar to basically a patient with COPD. You try to optimize pulmonary conditions. A lot of times the liver also is affected, so you need to consider giving vitamin K and avoid anticholinergics in these individuals, and tracheal suctioning can be something that may not be as easy as you think. Next one is, and ultimately what these individuals end up doing is they end up needing a lung transplant. That's the only way they survive. You get bilateral lung transplants. So it's a pretty big procedure. I know a family that has cystic fibrosis. One of their child died about a year and a half ago, and the other one's still alive. And they're very nice people, and you wouldn't be able to tell that they have cystic fibrosis by looking at them. They're really not that dramatically shorter than the rest of us. So it's not that, unless that person's really not being properly treated. Okay, if you're getting behind on the kid and you're not being really active on their chest physiotherapy, their work of breathing goes up. But the kids that are really well watched over, you can barely tell the difference. And what you end up happening is these individuals do get lung transplants. And both of them, the older brother didn't tolerate the transplant very well and passed within about 6 months to a year. The young lady, she's doing pretty well, and she's been already after transplant for about 5 years, and she's actually living a pretty normal life. So, she's still got the other problems with the pancreas and all the other issues. So I think they did also a pancreatic transplant on her as well. So all those things kind of help and make a difference in these individuals. But it's still, your mortality rate's pretty high. These kids are not likely to live beyond the age of 40. But in the old days, this was a death sentence before the age of 18. Okay, so we've improved it a lot. It's quite as bad. Nobody knows when you're going to die. You just don't. So always take every moment of the time to try to do the best you can with it. The next one is primary ciliary dyskinesia. Okay, this is actually pretty rare. It seems to have a higher population in California, Texas, and Virginia. So you get general impairment of ciliary activity. You get increased incidence. I already talked about that. Ciliary is located as part of the mucociliary mechanism, so these people have an inability to clear their lungs. They get insufficient mucus, and they develop bronchiectasis and increased risk of developing pneumonia. Almost all the males are sterile because the sperm cannot form the flagella cilia properly to work. If you look at, there's increased developing otitis media, chronic sinusitis, and hemoptysis. There's another one called Carter-Jenner's syndrome, which is a form of primary ciliary dyskinesia, which causes situs inversus. You can see here the heart is actually flipped. And they develop chronic sinusitis and bronchiectasis. Their actual layout of where they're located in the United States is slightly different. Okay, there's some in Nebraska, one in Washington State, Ohio. So there's different areas in Pennsylvania that have a higher density of these populations. No, just the heart, usually. You also have another disease called bronchiolitis obliterans, called BOOP. Okay, this, thank goodness, is a very rare syndrome. It's a chronic airway obstruction, which leads to eventual destruction of the bronchioles. We don't really know exactly what the total etiology is, but we think it's initiated maybe by a virus, or may also be seen in patients that are working in silos. They get exposure to nitrous dioxide. They develop these non-productive cough, dyspnea, and they develop what's called non-cardiac pulmonary edema. Treatments including steroids, immunosuppressions. Unfortunately, many of them progress to the point that they cannot breathe and they need lung transplantations. Thank goodness, it's pretty rare. I've actually only seen BOOP one time, so it is pretty rare. The next is restrictive diseases. So now we went from obstructive to now restrictive. Is restrictive, you have an inability to accept volume. Okay, so what I think of restrictive diseases is I always think of a boa constrictor around the person's chest. And just like a boa, the way it kills you, okay, is it waits for you to breathe out, and as soon as you breathe out, it squeezes a little bit tighter. So you're actively helping the boa kill you if you breathe in and out faster. Now, what you can do if you get a boa across your chest, what they tell you to do is just like in restrictive disease, is do shallow breathing. And it keeps you alive, and it keeps the chest from collapsing down, okay, which is what these restrictive disease people also have. What causes the actual restriction could be intrinsic lung problems or extrinsic diseases, which means outside of the lung itself. If you're looking at intrinsic, it's from the lung tissue is unable to expand. Things like pulmonary edema, increase in the elastin, or conversion from elastin to collagen, or forms of depositional diseases. As for the extrinsic diseases, that's where the chest wall itself is actually diseased. The actual lung tissue itself is normal. When you do biopsies of it, actually it's totally normal. But the thoracic compliance is reduced. Some things like morbid obesity, it's an example of that. Or reduced FRC diseases in pregnancy as well. Or you can have diseases of the pleura or mediastinum where they actually don't allow the lung to expand properly. Characteristics is reduction in FEV1, but also reduced FEVC at the same time. So you have a preserved what's called FEV1 to FVC ratio. But overall, you have a decrease in expiratory reserve volume, tidal volume, inspiratory reserve volume, vital capacity, total lung capacity, and residual volume. You also reduce compliance. So it's basically you're taking your spirometry and it's just squeezing it, and that's it. Okay, otherwise, the waveforms look fairly normal. And sometimes you also have an increased elasticity in these individuals. Characteristics is just, it's very common. So they do the rapid shallow breathing. Just like I was telling you before, if you had the boa around your chest, you breathe shallow breathing. Okay, it keeps you alive longer. Okay, if you decide that you're going to be scared and scream, the boa loves that. Okay, and after a while, you'll be like you can't scream in space. Okay, there's no more, you're in basically no more air in you. So don't do that kind of stuff if you ever play with boas. And it's becoming more of an issue in Florida. So, I thought the only time I was worried about the boas was when I lived in the Amazon basin in Panama. But here you have to worry about it now too because people are they're using so many pets. They're losing them in the Everglades. So, PCO2, or the PaO2 is usually decreased as the disease progresses. The CO2 doesn't really change that much because the person usually increases their minute ventilation to maintain. You do get the reduction in lung compliance, which is why you said increase in elastance. Okay, the normal values for normal values of compliance is 0.1 to 0.2 liters per centimeters of water pressure. In restricted disease, it's way down. It's about 1/10 the value, which is 0.02 liters per centimeter squared. How we actually measure this is by using what's called static compliance, not dynamic compliance. Dynamic compliance usually requires a machine to do that for you. But instead, static compliance will measure your actual plateau. So when you're looking at your pressure over time curve, okay, you take this value, and that's your delta P, and then your delta V is your expiratory tidal volume. Okay, so you do your expiratory tidal volume over your delta P in your actual plateau phase, and that's your compliance, which is your static compliance. Okay, pretty easy way to do it, and you can do that on any machine as long as you have a plateau. The plateau will actually tell you what you think will happen in this disease process. If you have a reduced compliance, what does that mean? It means for the same tidal volume you're delivering, you're requiring higher and higher amounts of pressure. So the delta P in this plateau here will go up with restricted disease. Not so much the peak inspiratory pressure, it'll go up with it too, but the actual number here, if you look at the person with this disease, this will go up, but it'll follow it. Okay, so PIP pressures also go up, yes, but with also the increase in the actual plateau phase. Acute intrinsic restrictive disease all lead to a decrease in lung compliance. All forms of pulmonary edema to a certain degree. The examples are aspiration pneumonitis, neurogenic pulmonary edema, negative pressure pulmonary edema, high altitude pulmonary edema, drug-induced pulmonary edema, the expansion of collapsed lung can also happen, pneumonia, cardiac pulmonary edema, or ARDS. So those are all forms of restrictive disease, of acute intrinsic restrictive disease. What is pulmonary edema? Well, pulmonary edema is pretty simple. It's a leakage into the actual interstitial space. But it has two stages. Stage one is one that actually goes into the interstitial space, and then it goes around the peribronchials. So one of the first signs of edema is not frothy sputum. It's actually wheezing, which can basically mimic asthma. Okay? But this is not an obstructive disease. Actually, it's a restrictive disease. The bronchial edema will then worsen, okay? The person will then, the actual fluid will begin to extravasate into the alveoli, wetting it. And that's stage 2. The actual interstitial pressure is high enough that it overwhelms the lymphatic drainage, and the person will actually get that frothy red stuff that comes out of the endotracheal tube. That's stage 2. Okay? If you look at aspiration pneumonitis, also known as Mendelssohn syndrome, is a lot of times from inhaled gastric content. It does not take very much. It takes around 20 cc's of a pH around 2 will kill you. Pretty high rate. So you got to be really, really, really careful. What really makes Mendelssohn syndrome worse is a low pH, so pH is less than 2, or large volumes have the worst prognosis, which is greater than 25 cc's. It leads to a destruction of the type 2 alveolar cells. Who cares about type 2 alveolar cells? What do? Right, they produce surfactant. So without them, you wipe out the surfactant. And there's a very high mortality with it. So you don't take aspiration lightly. It's not a joke. It seems to me that some people forget this all the time. And they put people that are high risk and give them LMAs. Okay? I had a great case the other day. I had a patient, about 3 weeks ago. I had a patient that came in, and the guy basically was telling me that he gets reflux occasionally, and he's slightly obese. He had a little bit of some degree of asthma. So I was talking to the student and said, let's intubate this person. And he goes, well, the asthma isn't cause this problem. We'll just put an LMA. And I go, no, let's intubate the guy. Because what I know, or I think I know, is that asthma a lot of times can be induced from passive reflux. Okay? It's one of the possible mechanisms of asthma. So we intubated the guy. The guy had been NPO for 8 hours. Last meal was at 10 o'clock at night, and we were doing this case at 8 o'clock in the morning. So he's more than 12 hours away. We intubate the guy. We don't really treat him as a rapid sequence because there's already no reason to. But we intubate him normally, so we get him intubated. During the middle of the case, green stuff just starts pouring out of this guy's mouth. Right in the middle of the case. For no reason. Absolutely nothing. The surgeon wasn't doing anything different. It just all of a sudden just welled up. We had almost 100 cc's of stuff coming out of his mouth. We suctioned it, got it all cleared up, and he didn't aspirate. And I can tell you, if he had an LMA, it would have gone right to the LMA, and you would have seen green stuff bubbling up and down. That guy would have died. Okay? So when you have that sort of feeling in the back of your head saying, no, intubate them, that's experience talking to you or your guardian angel, whatever it is, pay attention. Okay? What was interesting about the case is when we put an NG tube down the guy, he had 600 cc's in his stomach of gastric content. So he had some form of gastroparesis for some reason. He didn't have diabetes, didn't have any reasons for this. He just had it. So following that, we had him follow up by a GI doctor. Sure, they diagnosed him with what's called prune belly, not prune belly, but watermelon stomach, which means the stomach doesn't properly constrict down. He was put on Reglan, and guess what happened to his asthma? He got better. Okay, so one of the things you got to be watchful for that as well. Treatment is prevention is key. There's really no treatment once you get aspiration. You're on the bad end of it if that's the case. The amount of aspirin and pH is really what determines the outcome. If aspiration is witnessed, then what I do is immediately intubate. Okay, put cricoid pressure suction the mouth, intubate. Once you intubate, do not ventilate. Okay, as soon as you intubate, and you know you put the tube in the trachea, put a suction catheter in and suction the person out. It is really, really bad form to take a patient. If the person starts vomiting on you, what's the first thing you do? If they're awake, do you put more cricoid pressure on? No. If you put more cricoid pressure, you rupture their esophagus. If the person's actively vomiting. Cricoid pressure is only for passive vomiting. Okay? If the person's asleep and they start vomiting, then you clear the airway, which means you take, what I literally do is I will take my fingers and just crush the larynx. Okay? I'll just take it and just crush it. Boom. And it collapses everything. And then, as we do that, then we rotate the person's face out of the way and let the stuff drain out of the mouth really quickly. At that point, you better be intubating. Okay, which means the next point you do is you put the blade in, you start looking, and you get the tube in. As soon as you get the tube in, do not ventilate, because if some of the fluid is in the larynx, it's still not going to cause too much of a problem. But if you put positive pressure and you spray it everywhere, now you got acid all the way down to the alveoli, and that's when you get the type 2 cells wiped out. They're very sensitive to low pH issues. So what you do is you suction them out. The other thing that I've learned over time is that please, 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 when you're doing an intubation, do not raise the head of the bed up. I've seen people do that. It's really not smart, because if the person does vomit, okay, where's it all going to go? You have no chance then at all. It's going to go all the way down to the lungs. Okay, versus if you have them flat, it may still be sitting in the larynx and inside the trachea. So you can suction that out. And you prevent, hopefully, a degree of aspiration that's severe. Okay? The next thing you do is after you suction that person out, then you ventilate them. Make sure that you have end-tidal CO2, so you confirm that you have the tube in place. If you do the thing and you actually find out that your endotracheal tube is actually in the stomach, which may happen, or inside the esophagus, what do you do with the tube? Do you just take it out right away? How many people would take it out? Here's what you do. It's a great drainer of all the vomit that's coming up. Just take the tube, flip it over to this side, and let it drain the vomit that's coming up. Okay, make sure you stay away from it in case a person's actively vomiting, because it's like a snorkel, like watching a whale vomit green bile up in the air. It's just bad if you're on the downside of it. Okay? Or my favorite portion was spaghetti coming out of an endotracheal tube. It's when we intubated the esophagus. So it is very effective as a drainer away from the field, though. So don't take it out. And then go back in and look, and then put the tube in the right hole. And then do the same procedure. Suction them out, and then do the next thing. Hopefully you're not desaturating that point. Okay? But you got to be moving pretty quick in this situation. Okay? I've had a situation where the person was at full stomach. We had cricoid pressure. As soon as we induced him, he started bringing stuff up. We immediately intubated him, suctioned him out, and the guy did fine. Never had an aspiration. So we basically got everything out of his larynx. So we got pretty lucky. Okay. Now the next thing you do is after that, once you know that you're in, you've got CO2 back, you got breath sounds bilaterally, the next thing I do is I go down with the bronchoscope. And I pulled out peas, carrots. It's always fun doing that. That's always a bad day, by the way. Okay, but you can spend 2 or 3 hours doing that. You have to take all the particulate matter out. So you're there with a biopsy forceps pulling the stuff out. Watch your saturations. Okay, some people will tell you, oh, just wash the lungs. Do not do that. Do not wash the lungs with alkaline solutions or anything else. Just, if you need to use some saline to wash out some particulate matter, you can do that. That's fine. But really, you're not going to neutralize the pH by giving an alkaline solution. Now you can burn the patient on the other side of it. And don't do that. Okay? Watch your saturation. It will tell you the severity of aspiration. If your sat falls like a rock right away, you're in trouble. Okay? Immediately induce PEEP. Period. You have to prevent atelectasis at that point. So PEEP is going to be your friend. Okay? Supplemental oxygen, of course, be careful with it. Don't try to keep it under 50%, because that'll additionally injure the type 2 alveolar cells. Corticosteroids are really not a good idea. the chest X-ray looks great for 3 days and the patient dies. So I don't give steroids to patients that aspirate. Absolutely not. And antibiotics only if you're actively infected, so I'm not a pre-treater of antibiotics for these individuals either. The next one is neurogenic pulmonary edema. This can be from post-head injuries. It can be also inhibition from HPV. So we think it's a sympathetic stimulation which increases SVR. Treatment is to decrease the ICP and consider decreasing the SVR as well. Negative pressure pulmonary edema happens all the time, and a lot of times it's unrecognized. It can happen in a brief second. Okay? All it takes is just the larynx to close down, and the person has a forceful inspiration, and all of a sudden the person's in flash pulmonary edema. Okay? It always happens in somebody who's in good shape. Okay? Somebody who's not in good shape, you don't see that. Okay, most of the time. It can also happen when somebody is obstructing their upper larynx. The most common issue with that is somebody biting down in the tracheal tube. Bite down and take a big deep breath in, all of a sudden they're flash pulmonary edema. It's really fast. You also can see it with epiglottitis, laryngospasm, which we just talked about. And most people that drown don't have any water in their lungs, but they can go into pulmonary edema. Why do people drown without water in their lungs? The larynx closes. When you go underwater, your larynx will stay closed under all circumstances until you're dead. Once you're dead, then that's why you see when people die from drowning, what do? They float. You never seen dead people that are drowned? I guess not, okay, but they float, okay? They initially float. And after they're dead for a while, then they sink. So you know, okay? I guess I've seen some different things in my life, I guess, huh? Usually they sink within about 6 to 8 hours after they initially drown, which is kind of bad. I mean, you think about it, it's like, all you had to do is, so not to drown, was just to relax and stop freaking out and just taking a big air in your lungs and just float. I used to be trained to be a lifeguard when I was younger, and they used to hit that with our head all the time. Says if you're in a bad situation, just float, just relax, settle down. And it works especially in salt water. Anyways, endotracheal tube occlusion, that's where our biggest injury that we have. So please be careful. Make sure that you occlude. Don't let the person bite down the tube. It presents very rapidly. They get a frothy red sputum. It resolves with 1 to 3 hours after being treated appropriately. And the treatment is basically reverse your airway occlusion and then add pressure. CPAP, PEEP, or BiPAP. It doesn't really matter which one, just add pressure. And it keeps the alveoli from collapsing any further and hopefully resolves this issue over 3 hours. High altitude pulmonary edema is also induced by alveolar hypoxemia. We think it's HPV occurs in poorly oxygenated alveoli. So as you go up in elevation, the pulmonary capillary pressures begin to overpressurize and develops pulmonary edema. Treatment is basically prompt but descent and supplemental oxygen. Actually, I suffered from this when we went to La Paz, Bolivia. I was 12 years old, and La Paz is about the highest altitude city in the world that people live in all the time. And we landed on the C-130. As soon as I got out of the depressurized cabin, I couldn't breathe. I immediately went into pulmonary edema. So they threw supplemental oxygen on me, and they repressurized the aircraft, and it stopped. But guess what? We got to fly out that afternoon out of that place. So it was rather interesting. So people can go into rapid pulmonary edema very quickly, especially if they have underlying other problems like asthma. Okay. Nifedipine also can be used as a calcium channel blocker, and acetazolamide, which is a carbonic anhydrase inhibitor, can also be a little bit prophylactic to decreases high altitude pulmonary edema development. Re-expansion of lung pulmonary edema can be collapsed lung, high pressure volume resuscitation, high preload volume resuscitation. Chest tube placement can also cause this problem, or rapid expansion when chest tube is placed on suction. So I'm not a real fan of going to the highest pressure when you're re-expanding the lung. What I usually will do is when I put it in my chest tubes, and I've done enough in my life, you put it in your chest tube, you just leave it open to air for a second, and then you connect it up, and then you tell people, okay, gradually increase it. And you know that the lung's up because the person screams. Okay? The reason that's so painful is when the pleura touches the other pleura, it sends a nice sensory feedback. Yeah, the lung is back up. Okay? So that's how you know the lung's back up. If you re-expand it too fast, you put too much suction on it too quickly, the lung re-expands so quickly that it produces almost like a negative pressure pulmonary edema. Okay? On re-expansion, HPV goes away, okay, and the rapid preload return causes flash pulmonary edema on the pneumothorax side, and acute gas desaturation will take place. Basically, the best way is treatment, prevention, and if you do get in trouble like that, CPAP again. This is a person who's developed flash pulmonary edema. You can see it's on one side, okay, from this individual. ARDS is the next form of disease. ARDS is an adult respiratory distress syndrome. We think it's an immune-mediated inflammatory response leading to increased capillary permeability. The lungs literally become wet, okay, and as a consequence, the actual lung compliance drops dramatically. You get high concentrations of protein deposited in the interstitial space, and it causes translocation of neutrophils, disactivated, and it causes destruction of surrounding tissue by neutrophils, and so you have massive lung damage. You get massive reduction in lung compliance and FRC, and you have a tremendous increase in shunt and decrease in PaO2. Mortality rate in the ARDS is exceedingly high, 60 to 70%. The best way to avoid ARDS is don't get into it. In other words, don't give high oxygen levels, don't give this person high PEEP when it's not, or not high PEEP, but high tidal volumes. So things like that will cause problems with developing ARDS for acute lung injuries. If your ARDS etiology, of course, is prolonged shock states, that's why you don't let that person stay in shock for long. Sepsis, oxygen toxicity, which a lot of people forget about, smoke inhalation, DIC, drugs, aspiration, fat embolism, cardiopulmonary bypass, also in near drownings. What you see is you get significant reductions in FRC and compliance. The person has tachypnic, so all these people are breathing fast and they have decreased tidal volumes. They have tremendously increased work of breathing, so ventilatory support is appropriate, but you don't necessarily have to intubate some of these individuals at times until they get more severe. Sometimes I've actually seen people put them on a CPAP mask, and they seem to do better than trying to ventilate them. They get bilateral diffuse infiltrates. They develop eventually pulmonary hypertension, which may lead to right heart failure, thrombocytopenia, and multi-organ system failure. Basically, if you see this kind of problem, you consider the lungs are down. That's your first organ system. Every one organ system you lose, you have a 25% mortality rate. Usually with ARDS, you already have another lung. The kidneys are down by that point, and then you have cardiac failure next, which is then you have 75% mortality, and then when the liver fails, it's 100%. So you're pretty much wiped. Treatment is prevention is really key. Okay, I can tell you that we had two departments. One believed in high volume, and one believed in low volume delivery. In the low volume ICU almost had zero incidence of ARDS, and the high volume ICU had a very high incidence of ARDS. Okay, and they always say, well, they were taking care of the sicker patients. Nonsense. Okay, they were just doing it differently. If you give high tidal volumes to somebody who has already lung injury, you're causing progressive damage to the lung. Okay? If I take out half your lung, should I inflate you with the same amount of volume that I would give a person with two lungs? It doesn't make any sense. Okay, but people still do that in clinical management. Supplemental oxygen is really a double-edged sword. Okay, our ICU, or what we managed it, is we maintain a PaO2 greater than 60, and that's all we wanted. At 60, we were happy. So as long as the person was 90% saturated, we were sitting pretty. We accepted that. And we didn't try to drive them almost to 100% saturation, which would drive your oxygen levels to really, really high. CPAP and BiPAP are very effective in allowing the person not to collapse their lungs. Endotracheal tube and ventilation sometimes are required, of course, with the work of breathing overwhelming that individual. Some people believe in volume versus pressure. We tend to use PCV and those kind of damage and develop what's called a treatment called permissive hypercapnia, where you would just basically dial in your pressure control, and whatever the tidal volume that person was developing, you'd live with it, so that a lot of times they would become hypercapnic, which means that you're not very effectively ventilating. And you can live with that. I've seen people with a CO2 of 80 for a week. And as long as the PO2 stayed above 60, we kept that person alive, and all of a sudden the lung healed up, the tidal volume started jumping up on us, and we started dropping the PCV, and eventually we got the guy extubated. He survived it, okay? So permissive hypercapnia can be really a useful tool. One of the things that you do have permissive hypercapnia, the central respiratory drive becomes so intense that the person will try to breathe under all circumstances. One of the things you have to do is give them muscle relaxations. Cardiovascular monitoring of preload status is also pretty important, and you might have to give supplemental inotropic support. If you look at the chronic intrinsic restrictive diseases, these are the things like loss of pulmonary vasculature or pneumothorax may occur. Dyspnea is also pretty prominent. You get rapid and shallow breathing. Clinical examples of this are sarcoid, hypersensitivity pneumonitis, eosinophilic granuloma, pulmonary alveolar proteinosis or lymphangiomyomatosis. Sarcoid is a granulomatous disease that may affect the myocardium, liver, or spleen. The airway may be affected. The larynx may be affected in about 1 to 5% of patients. You get the lung and thoracic, you get lymph node granulomas. Corpulmonal may actually occur in these patients because they could develop pulmonary hypertension. And this usually presents with hypercalcemia and fever. So it's pretty unusual that this would present without fever. Diagnostically, it's usually metastanoscopy or the biopsies if you have a final lesion. Treatment is immunosuppressive therapy, giving the high-dose corticosteroids in these individuals. If you look at hypersensitivity pneumonitis, this is from dust inhalation. The signs and symptoms is over time the person develops dyspnea, cough after inhalation of the antigens. You get leukocytosis, eosinophilia, and arterial hypoxemia. Repeated attacks will eventually lead to pulmonary fibrosis. Then you also have a rare disease called eosinophilic granulomas. It's an autoimmune disease process, also known as histiocytosis X, which causes extensive pulmonary fibrosis, and it is an autoimmune disease process, so the primary treatment, again, is corticosteroids. These people have high amounts of eosinophils in their bloodstream. You also have this rare disorder, which is called pulmonary alveolar proteinosis. I've treated this when I was a resident and as a fellow. You intubate these individuals, and inside their lungs is full of this proteinaceous material. It looks like mud in the lungs. And what we do is we put a double lumen tube in these individuals and wash out the lungs with saline. Okay, and some people use other stuff that neutralizes the pH of the saline, which is they use saline has a pH around, I think, 6 or something like that, which is too low. So they give THAM in it, which is a form of not really bicarbonate, but it will make the thing more alkalotic and doesn't have any reaction in the lung. You mix it together by pharmacy and you wash out the lung. You do it by liters. Okay, so you wash out one lung, you flip the person and drain the water out of them, you do it again. And you fill up these jars full of stuff, and you can actually see the sediment level eventually clear up. You only do one lung at a time usually, and then you leave the opposite time alone. Some people are more aggressive and they do both sides, which I've never seen done. But I've actually seen people cured of this. So you do this for a week, you bring them back next week, you intubate them again, you flip them. You're the only people in the room. It's kind of funny. It's like, we normally never do that. We're always with a surgeon. It's one of the few situations where anesthesia is actually treating the individual. The other one that's rare is what's called lymphangiomyomatosis. It's usually seen in females of reproductive age. It's hypertrophy and proliferation of smooth muscle of abdominal lymphatics, thoracic lymphatics, veins, and bronchioles. It gets what's called restrictive and obstructive pattern, and this is progressive dyspnea, hemoptysis, pneumothorax is going to happen pretty frequently, as you can see in this picture, and they develop ascites. Death, unfortunately, ensues pretty promptly with 4 years, so the treatment's very, very low. And the extrinsic ones I'm not going to go into. I figured you've already read a lot about these. It's things like obesity, pleural fibrosis, failed chest, neuromuscular disease, diaphragmatic paralysis, Guillain-Barré. All these things we've already sort of gone through, and these are chronic extrinsic restricted diseases.